Okay, so welcome back again. Now we are moving to the micro level of health systems and policy interactions. And in fact, the transcript that you just looked at, even though it was situated at meso level, actually gave you quite a number of insights into micro level interactions. So just tell me, what are the other actors within the system that are pertinent to the dynamics of the meso level? What are the micro level interactions you noted in this context? So you mentioned nurses, right? What else? Patients and what kind of providers? Is there any mention of? Okay, so there's an interesting one that you mentioned, but you're not mentioning now. There's another, in the South African context, there is a person who is very, very important. No? No? No, no, no. It's what we would call an invisible actor. The security guard. Yeah. So I have a special interest in these kind of invisible actors because, for example, security guards in South Africa, there's a lot of these institutions, health centers and hospitals. Obviously, they have big security issues in many cities, but everywhere in the country, really. And there's always a security guard outside. And the security guard is usually intended to obviously protect and check who's coming in, who's going out, but they often play an unseen role in terms of triaging patients. So they will already decide who goes where, or they're already translating, for somebody who doesn't speak the language, and they're supporting people to get to the right place. And I find that fascinating. I always thought I would love to do interviews with security guards. A similar interesting unseen cadre in the Indian context in hospitals is the ward boy, right? Because they actually do a huge amount of beyond sweeping or cleaning or whatever. They're doing so much interactions with the patients and mediating between patients and providers. So when you look at actors, always think beyond the conventional actors that are typically representing the health facility or the health system. And think about those people like cleaners, like porters, like, as we said, guards, etc., and what role they might have, because often they fulfill, at the micro level, a social role, a software kind of role, in terms of enabling access, but also enabling communication, which can be very interesting. Okay, so just a reminder of where we are. We are at the collecting data stage, right? So we already have some insights at the meso level. At the macro level, we've been talking about policy, policy analysis, and using document review, using key informant interviews, using stakeholder analysis to obtain information about what's happening at the level of governance and funding structures, international versus local transfer of policies. We then went to the meso level and we talked about different kinds of theories that can be used to understand how collective groups, for example, patient groups or provider groups, how can understand the networks across them, and the power of those networks, the influence of those networks. And we talked also further about looking at things like organizational culture. Now, just to go back an instant, you might say it's difficult to capture organizational culture because sometimes we ourselves are so immersed in a particular culture, because as I always said, it's not as if the culture within the facility exists independently of what's outside, right? So if you as researchers come to a clinic, you are carrying your own baggage. You're already, so there's certain things you will not even notice. The issues of certain hierarchical relationships, the way people are behaving with each other, because it's very common outside of the hospital as well, right? Whereas if we take you to a different setting, you're going to be much more conscious of those things. So just be aware that issues of organizational culture are never very far from culture with a big C outside of the health system itself. And we need to think carefully about how we document those things. Good. We've also actually moved to some extent into some ideas about analysis, because everything you're doing is already analytical thinking. Yeah, you're ranking, you're prioritizing, you're looking at relationships, you're grouping, and you are establishing mini theories about why things are the way they are. Okay, so here we are. Okay, so now we're going to move to, as I said, the micro level of health systems. And I'm going to suggest that we're looking at the health systems from below. But below doesn't mean the bottom of the hierarchy. It simply means from the perspective of people's individual experience, their individual perceptions, their individual level interactions, okay? And I'm going to briefly remind you of the kind of schools of anthropology, medical anthropology, that inform how we look at human interaction, not only in health systems, but generally. And then we're going to look at a kind of thing that I've developed with colleagues, which is essentially around the relational approach to the health system. So what does it mean to take a relational approach? So when we first started, and I don't think we asked you really at the beginning we asked you what a health system was, right? And we said, please draw us how you conceptualize the health system. And I think all of you came up with quite interesting ways to conceptualize it. But if I had an even bigger group, and if most of you were not social scientists, but you were bureaucrats or technocrats or mainly medical people, your view of the health system might be one that we could label as a view from above, yeah? Which is this bird's eye view. Very much a focus on the functions, the components of the system, a normative idea, yeah, because you would want to be able to categorize the health system in a way that allows you to go around the world and similarly look at those functions, the financing, the governance, and so on. You also might have a view of the health system that is restricted to serving the purpose of addressing health. So you might not have considered the legal system or the transport system or the education system necessarily part of the health system, or even you might not have considered the community as part of the health system. Most work, as I said to you, before 2000 on comparative health systems started with this view from above, yeah? The boundaries were fixed. Biomedicine was seen as the gold standard, yeah? So most work on health systems performance was done in high-income countries. And in those countries, even though there was an existence of multiple traditions, but basically the orientation was around allopathic or biomedicine, yeah? So now we're going to suggest that, so this is kind of a monolithic view, right? So now we're going to move to a view from below, and you're going to say, well, we've been looking at it from below for the last 5 sessions already, so this isn't so radical a move. But we're going to do this more explicitly with respect to the micro level. So in this view, we're very much interested in practices, actors. We would acknowledge that the relationships across components of the health system are complex. Context matters. It can be chaotic in terms of how something has a knock-on effect. The systems thinking people would argue that there is a predictable way of looking at systems interactions, but it can be fairly chaotic too, because if you have a shock to the system that's unpredictable, things will get disrupted to the extent that it's not predictable, at least for a while, right? And we acknowledge in this view that the boundaries of the health system fluctuate. So even something as simple as thinking about the health worker who goes home at the end of the day and is taking care of their children, or taking care of elderly parents or in-laws, or doing some side clinic, a private clinic on the side, they're moving between boundaries, right? They are part of the health system, but they're also part of the community. And sometimes that moving back and forth is more explicit when you think about a community health worker program. They are positioned already between the two. But generally, any health worker is also a community member. Okay, we tend to forget that. In the monolithic view, it's just doctors are doctors, nurses are nurses. We kind of forget that there are lots of other things as well. And in this view from below, we also recognize that no matter where in the world you are, biomedicine or allopathic medicine is probably seen as having the highest perceived legitimacy or authority in terms of medical knowledge, but it coexists with many other medical traditions. If it didn't, we wouldn't see such a high demand, right, for different kinds of medicine. And I'm talking about rich countries as well. I'm talking about, you go into any pharmacy in Germany, you're going to be able to access not just allopathic medicine, but homeopathic medicine, which apparently originated in Germany, something I didn't know. And you're also going to find a whole range of other kind of complementary remedies. Nobody really acknowledges it fully because the traditional, the formal system is an allopathic system, but there are lots of options within that allopathic system that are open to you. So even in the street where my parents used to live, you go down the street and you'll see a clinic where there is a naturopathic practitioner, 2 Chinese practitioners, Chinese medicine practitioners, a holistic well-being something or other practitioner, and then in the same building you'll have your standard GP, your Hausarzt, which means a house doctor. So that's all under the same roof. Okay, whether they get along or not, we don't know, but they're certainly sitting under the same roof. All right, so that might surprise you because you think, oh no, over there in Europe, they're all oriented towards biomedicine. But in fact, it's pluralistic. All right. Okay, so now we're going to look at which kinds of actors make up the health system. And these are rather old photographs, so forgive that. But when we traditionally think, if I asked you, okay, who is part of the health system? These ones are fairly standard. Not very difficult to come up with these, right? Your mother-child clinic somewhere in Uganda, whether you see babies being weighed, you imagine maybe it's a community health worker or a lay health worker, a village health worker. A consultation somewhere in India where you visibly see through, again, the symbols of the white coat, the hat, etc., the positioning, you recognize, okay, that's familiar. Those are nurses and doctors, something you don't know what kind, but you roughly say these are some sort of health workers. Your surgical teams in an operating theater, it's also something that you instantly recognize across, right? When you go to this, pharmacists, would you say that they're part of the health system? But they're also part of a very highly privatized sector, right? They're also a business. Okay? But they're still part of the health system. Why? Because for many people who don't have a clear access or they don't have the time, if they've got some issue, they go straight to the pharmacist or the chemist shop. So I always found this very fascinating. This is somewhere in Bombay, that those pharmacists that are stocking all kinds of drugs, there is order in this chaos because they'll know exactly which row, which column to go to. I always found this very interesting because I thought, I mean, how on earth, right? And then this one is in Beijing, where you have an example of an apothecary, which is another name for a pharmacy, but a highly formalized one because, of course, like Ayurveda, Chinese medicine is a so-called grand tradition. It dates back many thousands of years, and therefore it's an institutional form of medicine, which means that the pharmacies have a high level of legitimacy and authority because there are schools, there's training, there are specific, there's specific research and development streams which are always testing the different kinds of preparations. But Okay, so we're expanding our mind. We're saying yes, nurses, doctors, but also pharmacists, right? But then we're also looking at these types of health systems actors. Okay, so these are traditional drug sellers in Myanmar, and you can see a range of roots, herbs, some kind of, I think these are porcupine quills, you know, the animal that has those very long things. And on the right-hand side, I find that also fascinating. So it's something like the Bombay market, where you have people selling allopathic drugs, some of them expired, some of them outdated, whatever, we don't really know. And that's in Peru. Okay? Now, this is also within the boundary of the health system, whether you like it or not. Because you're going to have people who use these. So when I was recently in Uganda, it was as bad traffic as here, by the way. So in Kampala, you get stuck on the road. And people are selling all kinds of things. There's like a moving feast of things happening. Pineapple, plastic bags, toilet paper, whatever. And then I'm like, wait, what is that? What is that? And there was bags of roots. So I said, and they said, oh, and the driver next to me laughed heartily, and he said he was a bit embarrassed. And I said, no, tell me, what is it for? And he said, well, you know, men's power. So I thought, okay, I get it. So all kinds of drugs. And you see that. You see ads all over the place, you know. Lost your love, we will help you re-find it. Lost whatever. You know, marriage broken down, we will bring it back to life, etc. So not just sexual health or potency, but also the predominance, people's need to satisfy a number of health issues through non-conventional methods, right? And so these drugs were being, not drugs, but these sort of bags of roots were being sold quite openly, and people knew exactly what they were for. Okay, so those are, this is to remind you, this is a very old paper, but I still like it. Jerry Bloom and Hilary Standing, who talk about medical pluralism and the marketization of healthcare. And I think it's useful because it really helps to remind us that no matter where we are in the world, we can think about the health system as spreading across actors that operate both within the market economy as well as the non-marketized economy. And the broader categorization is organized versus non-organized. So what they've done here is they have divided it according to the function, okay, public health, skilled consultation and treatment, medical-related goods, physical support of acutely and chronically ill, and management of intertemporal expenditure. So this is also different kinds of official and non-official, or rather informal ways of protecting people from financial risks expenditures. So the money lending schemes, those kitty schemes that people have, very, very common in Uganda. Again, most of sub-Saharan Africa is that people are part of multiple WhatsApp networks, but there's also huge demand, right? So, you know, I remember my research colleague there constantly getting messages, and I was like, what's happening, Justine? Why? And she said, oh no, it's so-and-so's, there's a funeral there, so I've got to contribute. And I'm like, but how are you contributing? And she says, no, it's a matter of whatever it was, the equivalent of 10 euros, 20 euros. She says, but when it's my turn and when my family is affected, I benefit from that. So, of course, there's very interesting work around your location in the hub of those networks, because if you're a member of somebody who works with an official health system, people call on you a lot more. You become a bit overburdened and burnt out. So we also saw that during COVID, especially in countries where, I mean, I'm sure in India as well, where oxygen supplies were low, the system was overburdened. The people who had some social capital in terms of their ties were really getting a lot of demand. Anyway, we're not going to go through this table, but this is a nice one to keep at hand because it will remind you that you could do this kind of exercise of mapping actors within any country. Okay, so again, this is a nice little paper that I pulled up yesterday. This is examining roles and relationships of actors in a community health system in Nigeria. And in many African settings, like here as well, the community health system is kind of the basis for understanding how health is delivered, especially for most parts of the country that are not privy to this, privatized services in urban settings. So it's a complex web. There are multiple players. They're producing, they're advocating, they're supporting health at household and community levels. Outside the well-known actors, there are many hidden players. So like I was saying to you before, I'm interested in those hidden actors. And they exist in the community health system, and their roles and contributions are barely acknowledged, but they're an important part of this web. So again, this is an exercise that you have started thinking about in terms of your stakeholders or your different kinds of actors. And here they're trying to do this difficult exercise of connecting them. So anything unfamiliar? Philanthropists, informal providers, and so on. Okay, good. So now we're going to suggest that anthropology is a discipline that has some unique insights or contributions to the study of health systems. And when I first went into, for example, I started working in London many years ago in 2001, the anthropologists were seen as kind of clearly social scientists, and the health systems people were seen as mainly economists. Yeah, it was mainly kind of dictated by economists or health services researchers. So the two didn't really meet. And then I had this very excellent mentor called Barbara McPake, who was interested in bringing in more social science, because she said, actually, what we see in the health system, even as economists, is that so much of behavior within the health system, thinking about performance incentives, or thinking about, financing reforms, why they work or not work, so much is about human behavior. So we really need closer collaboration with social scientists. And she brought on two anthropologists, one of them being myself. And we had a program which was called the Health Systems Development Program. And that was an early program. I think it ended in 2006. But it was very productive in terms of thinking about how anthropologists could more directly contribute to the study of health systems and policies. So anthropology, what does it bring to the study of health systems? It's a uniquely humanist perspective. And by humanist, we simply mean that, it's grounded in a very sympathetic view that no matter what your behavior or whatever your practices or whatever, we're always going to try to understand it in context. We're going to try to give it meaning. Okay, so there is no such thing as condemning, irrational private provider behavior. It is rational for them. Why is it rational? So it's up to us to uncover the laws that govern people's behaviors rather than labeling it as irrational or, a belief rather than knowledge, etc. So a lot of what we're doing in anthropology is bringing humanity to people in whatever situation they're in. Our stance is always going to be a relativist paradigm or constructivist paradigm, because we're in that unique position to really explore the tension between the normative construct and practical knowledge. So by normative construct, the normative construct could be, there are ethical guidelines. This is what we're supposed to be doing. You're supposed to be getting consent, protecting people's confidentiality as a provider. These are the normative guidelines. But we're trying to see, okay, so within their world, there's a breach of some kind of guidelines, but there's a rationale for that breach, okay? And the rationale might be, like you saw in the case of the South African clinic manager, is that they're operating under such constraints that they have to sometimes jump formal requirements and make ends meet. Or there is another cultural logic. And that logic could be as simple as I operate in a context where individual level consent has no meaning because patient autonomy is not a concept in India, or wasn't for a long time. This idea that a patient individually makes their decisions in a society where the family is so important to those decisions about health and decisions about healthcare. That individual level autonomy, taking consent from a lady who is about to have some kind of procedure, for the provider to call in family members is not a breach of guidelines. It makes sense given the cultural context. So as an anthropologist, you're always looking at what is the not just cultural, what's the cultural, the economic, the practical, the social norms that are governing this situation, that give it meaning, okay? Now there's two different approaches in medical anthropology that we use to shed light on human dimensions of the health system. And I'm not going to go into depth into them because I think many of you have some training in anthropology, but also because I think that's beyond the scope of this course. But the first branch is kind of looking at health systems as a cultural system. So really focusing on the ideas that drive the practices within the system. And the second one is looking at it as a social and political institution. So that is really more about the social relations, including the power relations. Okay? So you might say, well, I'm not sure about the difference between these two yet. Okay? So I'm going to help you with that. The approach to looking at the health system as a cultural system is also known as an ethnomedical approach. And it's an approach that comes from studying health and illness in the classical kind of anthropological way, whatever, not centuries ago, but maybe 200 years ago, in non-Western settings. And for cultural anthropologists, the focus has very much been on cultural meanings, ideas, and how they shape individual behavior in illness episodes. They're not so much interested in provider behavior, but their focus is on really understanding people's engagement with the health system. What influences whether you seek care or not, how you respond to advice or recommendations given, and so on. The emphasis is very much on patients, or on communities. And in fact, there's still a lot of anthropology that is taught which focuses on that level. Okay, they're not really interested in the culture of doctors. They're interested in the culture of people who are engaging with medical ideas, medical practices, medical systems. So there is something where culture is being reified at the expense of structural context. And reified means it's been given a status of its own. It's like this cloud which hangs over us, okay? As if everything that we do, our ideas, our ways of going about things, is culture. Okay, so there's not much attention on my structural status, my social status, my economic status. It is mainly focusing on culture. And I have to say that there is still a lot of anthropology that is driven by this idea of culture and its impact on ideas. The other approach stems from the opposite. It stems from the study of Western medicine. So for a very long time, in the pre-World War II period, the classical anthropologist in the West, in northern countries, was somebody who either was an armchair anthropologist, who didn't have the capacity to go and travel abroad, but they relied on accounts that were being brought back by missionaries or colonial administrators, and they would collect, as if they were collecting butterflies, they would collect beliefs and practices, and then they would write up these great big tomes about, the XYZ tribe in this country, the Balinese of Indonesia. And so they were really doing these comprehensive things. Then you get this move towards field work, where you get lots of anthropologists going out, spending a lot of time in the field. But then what happens in the 60s? What's happening to a range of countries that were formerly colonies? They're becoming independent. Yeah, India, of course, 1947, but African countries around the 60s, right? So nobody wants anthropologists hanging around anymore. In fact, they're seen as closely linked to the colonial enterprise. So what happens to the anthropologists who before were happily swanning around in, some place? I mean, it wasn't all easy, but they had the luxury of going out and spending long periods of time on some islands in the South Pacific, or I don't know, I'm sure in India there were also particular areas which had anthropologists which are famous. I know that as famous sociologists did a lot of work on caste in India based on field work. But what happened in the 60s is they were chucked out with the rest of the white folk that were still hanging around. So the gaze turned inward, yeah? And the anthropologists start to say, okay, let's look at our own institutions, yeah? So our hospitals, our healthcare delivery, and the 60s and the 70s is a very, very important period in North America, particularly. In the United Kingdom, less. There's not really much of a tradition of medical anthropology in the United Kingdom until later, I think. But basically, you have, you know, feminist movement taking off, civil rights movement, and later, of course, gay rights movement. And what that also led to is it's essentially a very fertile period for critical views, including critique of the biomedical system. So the anthropologists who are looking at their own systems in the US are starting to recognize how the medical system is gendered, how it is iatrogenic. In other words, it's producing sickness itself, right? How there are power struggles within the system. So the hierarchies within the system and how they lead to suboptimal delivery of care. And they're looking at things like mental health and how it's being handled. Because for a long time, mental health was medicalized heavily. And the interventions were geared towards, essentially, were quite invasive and quite barbaric almost. So all of that's happening in the 70s. And you have a branch of medical anthropology, which is closely aligned with political economy. So it's known as a more political stance, critical medical anthropology. And it's coming from the study of systems in rich countries, essentially. Very much a focus on social relations, access to power and knowledge at different levels of the system. And the emphasis here, interestingly enough, is not so much on patients, but it's on providers. Because patients are seen as victims of the system. And so they're really looking at power relations and how they shape authoritative knowledge in medicine and how they shape relationships in the system. What is interesting is that here, it's more a focus on beliefs, practices, knowledge, ideas, but nobody's looking at the structural context. Here, there's so much emphasis on the structural context that they're kind of giving less emphasis to subjective experience of suffering. Okay? So these are the challenges with the both, you know, with the two polar kind of opposites. Now, of course, I've given you a very dumbed down version of these two branches, and it's they're obviously much more sophisticated and they have evolved considerably since. But I think certainly when I was studying anthropology we were very aware of these two branches, and we knew that a lot of applied anthropology, as it was applied in, for example, public health, was predominantly this kind of anthropology and not the other. Okay, the underlying premises of the medical system weren't necessarily questioned. You might say, okay, they were very critical, but essentially biomedicine, it was, you know, the basic problem for the political economists working on health systems was not that biomedicine in and of itself was flawed, but that it was inequitably distributed. So the limitations of both of these approaches is that the patients or individuals are kind of pawns of the system, yeah? In one view, they're kind of dictated by culture, yeah? Which is why there's so much emphasis also in Indian anthropology for many years on cultural beliefs, as if people operated, you know, with this cultural cloud hanging over their heads, beliefs and practices. And we didn't really look at their agency, their ability to bypass, to overcome, to, you know, resist, to contest, and so on. Okay? There was just this idea that people behaved in certain ways because they were dictated by their culture. The sources of power and knowledge are kind of assumed and seen as static. So often both of these views don't capture the fact that things change. Culture changes, but also the political context changes, people's status change, and so on. And there was a lack of interest generally in how global health imperatives were translated in local contexts. So those working on kind of health systems as cultural systems tended to focus on specific cultures. So there would be, the health of X tribal group in India, yeah? But nobody was putting them in relation to the rest of what was going on in the country. It's very focused on small scale studies. There was also very little emphasis on actual practice. So what I'm going to propose is that with colleagues, we have kind of been drawing on ideas from both branches of medical anthropology, but also trying to develop our own way of looking at the health system that gives credit to the fact that people have agency in the system. Whether you're a provider or whether you're a patient, you have ways and means to navigate the space of the health system. Sometimes it's very constrained by your social position, but we still need to look at you as a dynamic actor that's operating within a structure. So if we think about a relational view, we're essentially moving away from the organogram. This is also a way of depicting a relational view because people in this organogram have a relationship to each other. It's a hierarchical relationship in the classical kind of organogram of a hierarchical organization. And we're looking more at this kind of relationship. So we recognize that formally this is going on, but we think that many actions within the health system are more dictated by relationships, so relational power. So we think that those relationships exist within the infrastructure. So what does this mean? We're going to look at a few different aspects. The first is that the material infrastructure and technology of care is deeply intertwined with social and power relations. So you could see that a little bit in the transcript that you looked at. But essentially, we're trying to understand the ways in which, in a health clinic, for example, the manager's ability to, let's say, fulfill her tasks in a satisfactory way is highly dependent on the space, the infrastructure, the resources, and the chain of command. They're all intertwined, yeah? This is a very high-tech new surgical unit. Where do you think it is? Any idea? You're probably checking out the people and trying to get a clue. It's in Rwanda. Rwanda is a country in East Central Africa, which has a very, very advanced health system. Surprisingly advanced in relation to where you think it would be coming from. But they have been working for many, many years with something called Partners in Health. In the US, I'm not really sure now what is happening with the new situation. But they have just instated these very, very high-tech surgical units. And I thought it was very interesting because my first thought was, is the system ready for this? Is there going to be a mismatch between implementing something that looks top of the, really, really top of the, top of the scale, technological systems, how is it going to match with existing workplace structures, routines, and so on? But essentially, that is one aspect of relational, is that you say that you're always looking at the relationship between the technical or the technology, the equipment, the infrastructure, and the social and power relations. The second aspect is, there's a title missing here, is really around understanding the epistemology of knowledge. So this is a nice quote from a book called On Asian Medical Knowledge, written many, many years ago. And it's essentially asking this question: how do patients and practitioners know what they know? What are their rules of evidence? What kinds and categories of information do they find persuasive, and under what circumstances? How do they know when a judgment is wrong or correct? And what does wrong or correct mean to patients, to a village practitioner, and to experts trained in the great tradition? Now, I find this very, very interesting because, again, it's coming back to the fact that you always have to situate what knowledge becomes important for you in what situation. So it's a kind of a realist approach to sources of knowledge and sources of authoritative knowledge. So it is relational because it is looking at the importance and the meaning of knowledge in a given context. Another way of looking at this, which is related, is thinking about health systems as knowledge economies. So they are dynamic because they offer ways of organizing access to expert knowledge or expertise that is embodied in both people and products. Yeah, the expertise that you see reflected in the new surgical unit in Rwanda is very visible because you've got this high-tech equipment. The expertise might be embodied in people who can speak knowledgeably about something, right? But of course, this is closely related to different types of power that we talked about. So I'm going to give you an example. This is an image from a pharmacy. And basically what happens, the interactions that happen in this pharmacy, there are two types of knowledge happening. What we would call explicit expertise or knowledge. So we might look at the two pharmacists behind the counter. We might analyze their expertise or their knowledge in terms of the tasks that a pharmacist and a pharmacy assistant has. But then there's something else going on, which is called tacit knowledge, which is the extent to which this elderly gentleman who comes in and who asks for something he doesn't have a prescription, we're going to analyze that situation a bit later, is provided with whatever drug he wants and information. But this is based not so much in their technical expertise, but in their social expertise. Okay, and it has, in this picture, probably a lot to do with caste, familiarity, assessment, an assessment of where this person is coming from. In fact, we're doing a study in Belgium now to understand pharmacists' tacit knowledge in terms of their behavior with patients of a migrant background. Okay, so this is a very interesting paper, which I think what is happening is that when I move the slides from colored slides to white slides, it's missed out some of the text, but I will make sure that you get the reference. So here the use of tacit knowledge can be applied to the pharmacist who makes an ethical decision about whether to dispense a prescription-only medicine without a prescription in an emergency or the reporting of suspected misuse of drugs by a client or colleague. The knowledge involved in making these complex decisions cannot always be verbalized, and it's based on experience rather than formal theory. Okay, so again, a relational aspect of the health system, which suggests that the way in which people assert their authority or their expertise is not always by virtue of having a certificate on the wall. It is something that is gained through experience. Okay, another aspect of thinking about this relational kind of contributions of anthropology to the health system is that when we conduct conventional research, especially when you think of positivist-driven survey research, we think of measuring things as a one-off, unless we're doing a longitudinal or before-after study. But usually we don't think about the fact that people have a long-term engagement over the course of their, say, women for women, over the course of their reproductive lives, or for people in general. You have some kind of ongoing engagement with the health system. So it's not a one-off event. And that also is a relational approach, because it's saying that when we go out and try to understand people's illness behaviors or their interface with the health system, we need to think about it in relation to their previous experiences. Why do mothers not take their kids to be immunized? Because their last experiences of the health system were so poor that they have no trust. Yeah? We don't, unfortunately, most of our research doesn't consider that. We tend to think of the here and now. Yeah? Okay, I'm going to give you a nice example from a paper by Marion Loveday, which is looking at a patient pathway. Okay? And this is essentially a paper which is following one single patient. The whole paper is only about one patient. But it is a paper which looks at what happened, why the pathway to care was compromised. So this person has drug-resistant TB, and the legend, they basically tracked what happened over the course of, I think, probably almost a year. But essentially, it shows you 10 out of 24 months, they were given full and correct treatment, 4 out of 24 months, no treatment, and 10 out of 24. So if you look at it from a point of view of patient adherence to treatment for drug-resistant TB, it doesn't look great. When you analyze it as not a one-stop thing, but you look at the course of what happened, you can see months the patient received no treatment, months they received incomplete treatment, months they received full treatment, health systems factors and patient factors. And then we look at what actually happened. So at one point the laboratory website was down, so the information wasn't communicated accurately. There was a public sector strike. There was a stock out of a major drug, heavy rains, which led to the person not being able to access the facility. The medical records were lost for the person. No transport money, there was a missed visit, and there was another stock out of another drug. So in balance, it's a mix, it's a complex mix, but essentially one that very clearly illustrates the relationship again between patient delays, systems delays that are a result of a number of factors that are beyond this person's control. So this is a really excellent paper, and I believe that something similar was done in India with our colleague, with Sheila Rangan, which is, it's a paper called Such a Long Journey. And I think they modeled it, in fact, on this paper. I'm not sure. Maybe it came before it. I'm not sure, but it was similar. And this is also to illustrate to you that sometimes taking the time to understand one trajectory can reveal quite a lot. All right? So the relational aspect here is the issue of the temporal aspect, that when you think about engagement with the health system, the classical way is you just measure one-off visits, but think about it as a long-term, especially for people who are on a long-term treatment. So this brings us into the kind of broader notion of temporal and spatial dimensions of health systems encounters. And I've mentioned this before, my example for thinking about the ways in which space and time matter for health systems strategies. This is HIV testing and the move from, as you remember, provider-initiated testing and counseling through voluntary testing and counseling through to self-testing. And what we argued in an editorial some years ago is that we said the tests are becoming much more rapid, they're becoming routinized. But what is happening also is that we're changing the time and space dimensions because they're taking place outside of the clinic. So we're going more and more into intimate spaces, right? The testing used to take place in a clinic, then it moved into mobile testing camps or whatever, and then it moved into homes. So that transition is important to think about, what it means for the person who's doing the test. So there's a continuum of social spaces spanning the intimacy of homes and the relative anonymity of mobile testing facilities. What's also happening is that the time is changing. So in the beginning, years ago, when you had an HIV test, you had to wait 3 days for the result, right? Then we moved into a testing and counseling situation where you would get the result within a shorter amount of time, but there was a kind of delay in terms of the diagnosis being fed, the post-test counseling, and so on. And now we're moving to a situation where you essentially have it within minutes, like a pregnancy test, essentially. So our argument on the basis of work that was done in Kenya and Malawi was that rapid testing technologies may paradoxically deprive individuals of the time required they need to digest the test, the result, and its consequences, and to think about when and with whom to share test results. Okay, so this is just a very concrete example of why, again, thinking about the relational aspects, why time and space matter in health systems, and there's many other examples. Okay, the last one is, this is a very sort of simple idea, but it's often ignored in health systems thinking, is that, but you saw that in the paper that we just looked at, the South African paper, is that you have what's called, so again, my mentor, Barbara McPake, she referred to this as the dynamic responses model. So on the one hand, you have the de jure system, okay? This is the system that's laid down in protocols, in guidelines, codes of conduct, organizational structures, the incentives, the procedures. These are the things that are implemented in the system. Then you have the de facto system. The system is experienced by people. They receive better or worse, they're able less or more to access the system. They receive better or worse quality of services. And there's something in between, she says, is the dynamic responses. So it's how users and providers react and interact in response to the formal structures. And this, the argument is that very often it's negotiated through informal processes. So the de jure system, the one that is officially in place, legislated, mandated, according to regulations, is the only place where we can intervene, technically, if we're health systems people. But there is no direct link to the de facto, which is how people experience the system. So everything is mediated through health systems actors. And operating at the micro level, we are interested in adaptive responses, yeah? Especially in situations where we know that it is close to impossible to implement the guideline or the initiative as it was intended because of the circumstances. So, for example, in the de jure system, you might have a situation where user fees are removed, and it means that you're getting greater numbers of people coming to use the system, but the providers, because of their own constraints, might react by charging on the side. There might be some informal payments going on. And the users might then react by sourcing cheaper drugs from informal sources. And so all of these interactions are really about how both sides of the provider side and the community side or the patient side are adapting. And I think in her case is Barbara McPake did a lot of analysis to see why, even with all the initiatives that have been put in place to improve access of the poor to the system, that in fact the poor don't benefit because there is something else going on whereby people who are slightly better off are able to co-opt the system. Okay. So we've talked a lot about practice. So how people, what's going on within the system in terms of what they know. So that's the epistemology, what they're doing, praxis. And now we're looking at social relations. So this is the social embeddedness. And this has to do with what we refer to as relational power, or sometimes we refer to as social capital as well. And there's a nice paper on, again, individual patients' capital in terms of navigating their way into the system. And this author argues that some people are just better at finding the right person to ask where to go, presenting their sickness within the right time frame, and at presenting themselves respectfully. And I'll never forget, I had an example from my own fieldwork here in Maharashtra. I was working in Bobkil, which is somewhere outside here. And we were working with women and trying to understand, issues about their reproductive health, how they expressed it, whether they sought care. And we worked through a local, I think there was a local women's Mahila, like a temple-based organization, not organization, just a social association. And there was this very, very strong, very articulate woman who was somebody who helped us in terms of gatekeeping to the community. And this lady had some problem. She had a gastrointestinal issue which wasn't going away. So I agreed to take her to Sassoon Hospital. And in the course of that trip, I saw her status as a strong community leader, outspoken, defiant, always very well presented, crumble. Why? Because she was moving out of her comfort zone. And as soon as we reached the hospital, she was treated so poorly because she was recognized as somebody, had the traditional way of wearing her sari. She spoke a certain type of Marathi, which what the receptionist, and I saw progressively how she completely lost her status and her capital. So her capital that made her a prominent person in the community effectively was diminished in the health system because she didn't have the ways to present herself as a good patient. Okay, she couldn't articulate exactly what was happening in terms of presenting symptoms. She didn't have the ability to articulate even things about her personal background because she didn't really go to the hospital that often. And at that time, I was absolutely shocked to see that because it made me realize that it is not so much the conditions and the severity of the conditions that determine your care. It's also little things like this. It is how you present yourself, okay? And it's what's called the good, what is the good patient versus the bad patient? And the good patient is often somebody who goes and knows exactly, there's a shared language, okay? Yes, doctor, I've got this thing, I think it's gastrointestinal, I'm not sure, but I did this, okay? And the other patient is somebody who is articulating their complaints, but not in the same language being in apostrophes, okay? But this stuck in my head for years because it was such a powerful symbol of how the health system can disempower people just by virtue of a small thing like that. So that's kind of that. That's this issue of how the good patient and the not bad patient, but the inarticulate patient can lead to different access to care. And then, of course, we're looking at power as it's expressed through many kinds of social relations at multiple levels of the system. And we've talked about this a lot. Social interactions, the people involved, the structures within which social processes that they all influence power dynamics. And there's some excellent work on this. So let's look at another typical example of a scenario where power is very visible, right? This is the ward round. Yeah? And you will instantly recognize who is who by virtue of what? What are the symbols that immediately give you clues as to who holds authority here? Yeah, the codes, maybe the positioning, maybe she's probably the most senior, right? This one. Which is quite refreshing, but the distance, who's allowed to go closer to the bed, who's further away, the demeanor, yeah, who's allowed to ask questions. So there's papers, imagine there's papers unpacking the ritual of the ward round because it is such a highly symbolic aspect of medical training. And they talk about it being a ritual of hospital life, which brings some sort of stability. However, ward rounds may actually simultaneously reconfirm existing hierarchies in the workplace, inadvertently reaffirming submissive social roles, for example, of nurses and patients, and hierarchical control. So different kinds of information are distributed between members of the team and the patients during the ward round, but this in fact determines the type of contribution that is deemed valid or not. And my son, who's now second year medical school, is constantly giving me examples of this. Whenever they do some kind of work in a health setting or shadowing a GP, there's so many aspects of this in terms of when are they allowed to ask something, how are they allowed to ask it, who gets to ask, who is listened to, who has direct eye contact, all these little things, right? So the ward round is a very fascinating ritual. Okay, let's stop there. Are there any questions on this section before we move forward?